system. We'll be discussing about constipation and malignant bowel obstruction today. Hope you all are clear about nausea and vomiting and you have read about it. So today we'll be continuing with constipation. There is no rocket science things in this topic. Last time we had all the receptors and all the like little bit confusing things. So this time you will be listening to few things which you'll be knowing, but there will be certainly new points and so many things you'll have to explain to your patients that will be helpful in your clinics also. So listen carefully and we'll start. We'll start with the class. Okay. So first we'll deal with constipation. So constipation, it is defined as a difficulty or painful defecation, and it is associated with infrequent bowel evacuation and hard feces. I have written four things in red color. Difficulty or painful defecation, that is the first one. Then infrequent bowel evacuation and hard feces. All these three things are very important. Most of the time, the patient will have any of the three symptoms. It's not like you should have all these three things to like tag them as a patient having constipation. So, 45% of the palliative care patients are constipated during the time of admissions. Just a data, like the point in that is you have to ask about it. Most of the time, the patient will not be telling it. So, it will be there. You have to ask and you have to fight. So, not only this definition, I have defined as a difficulty or painful defecation with infrequent bowel evacuation heart pieces. But sometimes it is subjective. For some patient, that means how it is different from their normal. For some people, bowel opens twice in a day, and for some only it will be once in a day. So if they tell that if they have difficulty and there is a difference in their pattern, it should be considered. Okay. It's not like the patient is telling, yeah, bowel opened yesterday. For mine, every day it will go only once in 2 days. Not like that. For each person, it will be different. So you need to assess the symptom carefully. So in history, most of the people will be very hesitant to answer, and also we'll be shy to ask how is your bowel opening. It should not be like that. It's very important. You have to ask what is your normal, how is it going, frequency, amount, consistency, is it blood stained or not? And this question, the next question is very important. When was the last satisfactory bowel opening? Sometimes when you ask, did the bowel open? And they'll tell, yeah. You should change your question. You should ask, when was the last satisfactory bowel opening? Then the answer will also change. They'll tell, yeah, it was 5 days back. I had a satisfactory bowel opening, but yesterday only little. Like that. So when you take a history, you have to ask about this. Okay. You should not be shy. If they become shy also, you have to help them to tell you. Okay. Whether another thing is whether he has any discomfort, cramping, nausea, vomiting. Most of the time, most of the patients having constipation will be having all these problems also. And one common thing, the next point, the elderly patients. Most of the elderly patients will be having this kind of constipation and they'll be taking their own laxatives. So sometimes when a disease comes, their constipation increases. So that is also important whether the patient was having a chronic constipation and if it has recently changed or not. Then you have to ask about the diet, what diet they are taking. Okay, so these are the things you should ask in the history. And very importantly, in this slide, you should not forget the last satisfactory bowel opening. Okay. Now I'll show you a Bristol stool chart. You can get it in Google and all. This is to help to understand even for the normal people, like how their stools are. So the type 1 and type 2 is considered as like patients having constipation. Type 3 and type 4 are also considered as normal, and from 5 to 7 it is considered as diarrhea. You can check it later. You can get it in Google and all. This is a Bristol stool chart. In our IP, we have a chart kept there, and we can ask patient very easily, how is your stool? Now, what happens if constipation is not tackled in a proper way? That leads to feeling of incomplete evacuation. The patient feels like he wants to go to toilet again and again. Then a bloated feeling, he'll feel that, oh, abdomen is feeling very bloated, it is distended. Patient develops nausea, vomiting, abdominal cramps, pain, bowel obstruction, overflow diarrhea, and urinary retention. Two things will be new here, I think. Overflow diarrhea that we'll discuss a little later. How will our constipation cause a urinary retention? Urinary retention is a emergency situation, right? Sometimes in our OP, patients will be brought telling that, oh, doctor, the patient has not passed urine since like 1 day. And what will you do? There you have to ask a question. Has the bowel opened? Sometimes they'll say no. What is the significance? Because this hard stool, the constipated stool, will press on the bladder or will press on the urinary tract, like the flow. It will obstruct the flow, and that can even cause constipation. So don't forget about it. Urinary retention can be caused by a long-term constipation. Okay. So now another important thing we usually come across when you ask about constipation, the question when I talk to my patient, like how is a bowel opening, and the family, the primary caretaker, caregiver will answer the question. See, doctor, he's not eating anything. Then how will he pass a motion? As if I've asked a stupid question. So that is because of their concern. And most of the people will think that if we don't eat anything, nothing will come up. Is it like that? To avoid that, what you should know? You should know what happened. Okay. You should know that you should counsel that stool contain shredded epithelium and a major bulk of bacterial byproduct. It is not only the food. The food, little food also, that will be degraded by the bacteria and that will be also present. So if the patient has not taken any food also for few days, he may need a bowel care. Maybe a little quantity will be there. If that is not more, the patient will have constipation. It will keep on accumulating. So you have to counsel the family member regarding this. Okay? You have when the family say like that, you should know to tell. You should tell them. See, there will be other ways also. It is not a okay. We understand that you should like acknowledge them. Okay, we understand that the patient is not taking food, but at least a little quantity will be there formed by the bacterial byproducts and all the shredded epithelium, body waste and all. So that has to go. For that, you need to clear constipation. Make them clear. Okay, it will be difficult then for to understand because it is a new thing. Nobody will be knowing. Now, what are the causes? What are the common causes of constipation? So, our important opioid, our major drug, opioid will cause constipation. Antidepressants, when we commonly prescribe anticholinergic, anti-epileptics, and oh, everything is there. All our palliative care medicines are there. So, all understand that our medicines can also cause constipation. Okay. Other things like metabolic dehydration, hypercalcemia, hypokalemia, uremia, all these can cause the this thing, the bowel movement, peristalsis. So that can also cause. Then the important one, diet, like the patient's family is telling him he's not taking anything. That is also a reason. It's not like no, not because of that. That is also there. Patient is having poor appetite. Patient is not taking fluid and fiber, and like that. Diet is also important. That can also cause constipation. Now, environment, that is also important because most of the patients, when they get admitted in hospitals, there is a change in environment. Hospitalization, they'll be going to their own toilet, change in the place. That will say like some people are there, they'll go to washroom only in their own house. So that will be there. Then most of the people they'll not be having anyone to help. I have seen a few patients telling like they are becoming a burden for their family. So they don't want to disturb anyone. So I'll keep on holding my bowel. I have come across such patients. So that is also there. That should be also kept in mind. Then certain neurological condition where there is nerve compression, like malignant spinal cord compression, where the patient present with retention and constipation. Sacral nerve infiltration, like in the sacral region, due to tumor and all, the nerves will be infiltrated. This bowel is moved by peristalsis, also by neurological things. So that will be also a cause. An important one in our setting, the pelvic tumors, like in the ovarian tumor or the tumors in the alimentary canal can cause. RT-induced fibrosis. What is RT? Radiotherapy. Radiotherapy. Post radiotherapy, the patient can get fibrosis. The proper peristalsis will not occur, and the patient can have constipation. Intraluminal obstruction. The malignancy itself obstructing the lumen can cause constipation. Other things like depression, the patient will not feel the feeling to have a bowel opening will not be there. Weakness, immobility, bedbound patient, for them constipation is common. So I'll a few points about morphine, since we are using morphine very frequently. Why morphine causes constipation? Morphine do everything to cause constipation. You have to think like that. It inhibits the peristalsis first of all. Okay, by decreasing the propulsive activity. Then it causes additional time for water reabsorption. We keep the stool there. It will not cause peristalsis, and the stool will be in the gut for a long time. And by that time, our body will reabsorb all the water and stool will become hard. And it also increase inhibition of secretomotor neurons. At least if they are staying there, the neurons will provide some secretion, but morphine will cut that also. So and reduce the sensation of rectal distension. Okay, so morphine is doing everything to cause constipation in all means. So this should be kept in mind. The hand that charts morphine should chart the laxative. Whenever you write morphine, you should also prescribe a laxative. Otherwise, it is a negligence. Okay? You have to write morphine, bisacodyl along with morphine. Okay? Don't forget this. In the last class, we studied, no? Before we anticipatorily start perino or metoclopramide before starting morphine for at least 3 days. Like that, anticipatorily, we will write bisacodyl along with morphine. So coming to the management part, first we'll go with the non-pharmacological method. We can, every time it's like that, right? So we arrange like accessibility to toilet should be facilitated. They should have a nearby toilet, like that. The patient should have a good access. Somebody should be there to take care of the patient. We have to tell them, we have to reassure the patient that you are not a burden, or it is not like that. You have to address that. Timing and privacy. In a hospital setup, it is a very common thing. The patient may sometimes a bedbound patient or patients using commode chair, they'll be sitting and passing the motion in a open ward. Should be allowed? No, we have to give them privacy. At least keep a screen and tell them that yeah, it is closed. Okay, now you can use a toilet. Like that, you have to make arrangements for that for those patients who are bedbound. Now, squatting position. Sometimes the patients will be their habitual thing. They can pass stools only when they are in a squatted position. That had for those patients that is possible. Try to do that and improve dietary habits. So these are the non-pharmacological things that we can do to improve constipation. Okay. Now coming to the laxatives. This is also very important. So somebody is coming to you, okay, and telling, yeah, doctor, I have a constipation. Okay, then you will tell, yeah, I know one stool softener, Grimafin, or I know lactose. Take it. That will be enough. Is it right? No, it is not right. We have different groups of drugs and everything acts differently and not everything works. So you have to know what is what. And you can't tell like, ah, you take that, you take this. You should definitely know how these drugs act and how it is going to help. Okay? So first one is a stimulant laxative. It is bisacodyl. How it acts? It has a direct action on the mesenteric and submucosal plexus. Stimulant or irritant, it will cause a stimulation. Okay, and that causes the bowel to pass out. But it should be avoided in complete obstruction. In other ways, we can give bisacodyl. But if the patient is suspected to have a complete obstruction, what happens? Sometime in an obstruction, the peristalsis will keep on happening. Okay, and the patient will get pain. And when you give a stimulant laxative along with that, the patient with complete obstruction and having a pain, when you give bisacodyl, the stimulation occurs and the peristaltic movement increases again. That might increase the pain. So we usually don't give bisacodyl in patients with complete obstruction with pain and all. Okay. Otherwise, you can give stimulant laxative. For morphine, you need to give a stimulant laxative. That's why we give bisacodyl for these patients. Now coming to prescription of morphine, we can give bisacodyl 10 milligram plus or minus softener. So the softener is optional. Okay. If the patient is telling hard stool, we can give a softener. That we'll talk later. Next. So first we'll do is we'll give bisacodyl tablet along with morphine. And if the patient is having constipation, we can increase the dose to 10 milligram BD and then up to 10 milligram TDS. We can give. Okay. That all along with plus or minus softener. So what is this softener? Stool softener, it will make the stool very soft. Sometimes the patient will be telling, every day the stool goes, but it is very hard. Daily I can pass the motion. Only thing is the hard stool is causing pain. For that, we need stool softener. Okay. So that is stool softener which we use liquid paraffin, cremafinol. So the next one is osmotic laxative. Example of that one is lactose. The syrup loose. You are prescribing syrup loose. What happened? It is an osmotic laxative. Osmotic laxative is that it draws fluid from like to the intestine and it increases the bulk and it causes the outward movement of stool. Okay, that's how osmotic laxative act. So it causes what it is written water retention in the lumen. So the two caution is that it causes dehydration. It is pulling fluid from our body. This osmotic laxative, so much of water will be lost. Already our patient is not taking any food, maybe having nausea, maybe having vomiting. So along with that, if you give a osmotic laxative, the fluid, the only fluid which is present will also go out through the motion. Okay. It can also cause cramping and nausea. It is not like very evident, but still, these are the problems of osmotic laxative. So usually we prefer, along with morphine, we give bisacodyl and then at least a liquid paraffin. Okay. So this one is bulk forming. In the chart, I have isafgula, where we don't use it very regularly because it is a bulk forming laxative. It increases the fecal matter. So some patients who are having severe rectum and all, it will be difficult for them. Increasing the bulk too much is not that helpful. So we don't use it very commonly. Okay. So now we have given all the medication, and the next one is digital rectal examination. It is very important. When a patient complains with constipation, and if it is for a long period, you can do a rectal examination and see how the rectum is. So, how to do a rectal examination? Can someone tell? I was talking continuously. Can someone tell? Like every day we do a very simple thing. Just I want to add one point. So can someone tell how do you do a PR examination in a very simple way, just in few words? Can someone unmute and tell?
Hello.
Yeah,
Yes, ma'am.
till now. Yeah.
I'm working in a palliative care hospital
Okay, good.
in Pune.
Okay.
So there are many patient has it started with morphine and they have this side effect of constipation. So every third day, if the patient has not passed motion, we do this PR examination
Okay.
First of all, we inform the patient and their relatives. Then take their permission.
Yeah.
The articles which we use is gloves,
Yeah.
lignocaine jelly,
Yeah.
and cotton pads if necessary. And if then and there, if we decide to put an suppository or bisacodyl, um, enema, then वो भी लेते हैं.
Okay.
Then patient will give the patient position, left lateral
Yeah.
mostly.
Yeah.
Then we insert our finger,
Yeah.
and हम देखते हैं कि हार्ड स्टूल है या फिर सॉफ्ट स्टूल है.
Yeah, so
And
one
we inform.
very good, Sunaina. So I just want to add one point is that while we are inserting the finger, we use a lignocaine jelly, right? So we have
Yes,
to
yes.
wait for some time after applying the lignocaine. What we do is we have to finish our job, right? We have to finish our job so very fast. So we'll do it at that time itself. Wait for some time to act. Sometimes the patient will be having pain in the anal region also. So wait for that to subside. Also, one more thing you can do is you can talk to the patient. You can you can talk to them and you can divert their attention. Then they will not hold the thing very tightly. Then you will be able to examine very properly. Thank you, Sunena. So we'll continue. So that's how we do a PR examination. And then we look for how the rectum is. These things you have to understand. Okay. If the rectum is empty and collapsed, it indicates that there is a functioning bowel. It will when you insert and if the rectum is empty and it collapses, it means it indicates a functioning bowel. If the rectum is empty and dilated, it indicates that something up is there, and so it is not coming, we are not getting it, it is up somewhere. If it is feel balloon, it indicates a gross constipation. Okay, we feel that a roomy sensation in the rectum. And if there is feces in the rectum, determine the consistency, whether it is hard or something. Sometimes you'll be able to feel the tumor. If some kind of rectal malignancies are there, you can feel the tumor also. Okay. So how do we manage if the patient is having a soft stool? The consistency is soft. You can just keep the bisacodyl suppository. It will cause a local stimulant effect, and stool will come out. And if it is a hard stool, if we can give a glycerin suppository to make it soft. And if it is an empty rectum, we can give oral stimulants or higher enema. If there is a balloony rectum, and if you when you are inserting and if you feel that it is very roomy, it means our stool is very staying somewhere up. So we have to give higher enema. Okay. So few things to remember in now we were talking about patients with malignancy. So some paraplegic patients will not be also having this kind of um, like constipation. So for them, we also have to give regular stimulant and stool softener, because they will not have sometimes with traumatic paraplegia, they will not be having the power to push the stool out. Okay. Or sometimes when the patient is bedbound, there will not be any movements and all. For those paraplegic patients, we can give stimulant laxatives and stool softener. Also, in patient with some colostomies might have all these kinds of problems. For them also, we can do bisacodyl. Can give bisacodyl suppository after ruling of obstruction. So now the next thing what I'm going to tell is very important, because you will come across this in palliative care often many times. You have to understand it, and if you want to tell that to others. Okay. So in a scenario where the patient, sometimes you'll get a call from the patient's family member telling, patient was having constipation for a long time, but he started developing diarrhea. And you'll be confused. How does that happen? After a long period of constipation, the stool has to get a hard, no? Then how can a patient get diarrhea? For that, you should know this. This is known as overflow diarrhea. This happens when there is a constipation for long time. Okay, long at the stay in the gut, our body will take away all the water. The stool will get hard and hard, and the constipation increases. But what happened in our gut? There are someone called bacteria. Gut bacteria, it act on this hard stool behind. Okay, not on the anal orifice, behind. And it will cause putrefaction, decomposition, putrefaction. And the stool becomes watery. So this stool comes out through the sides of this hard stool in small quantities. So typically they'll tell like watery stool in small quantity after a long period of constipation. This is known as spurious diarrhea. Okay. So if you have to understand it, you will get called. You have to, when such a scenario comes, a patient having constipation for a long time, suddenly presenting with frequent, very small quantity of liquid feces, then you have to think about this overflow diarrhea. People will, they will, you will, when you ask whether the patient is having constipation, the caregiver will tell what doctor, what sister, when I'm talking about constipation, you're talking about, no, when I'm talking about diarrhea, you're talking about constipation. But you should make them understand. You should tell them, you should be able to explain this. There is something like this also. It could be this. We need to know. For this, you have to do a rectal examination. See if there is a like a stool go in the up, like a roomy rectum. Patient might get. So you have to rule out this. Okay. Sometimes it can be even diarrhea, but you have to differentiate this from spurious diarrhea. For to differentiate, first you should know what is spurious diarrhea. Okay, all clear? All clear?
Yes, ma'am.
Okay, good. So, okay, that's the end of constipation. Now we'll go with malignant bowel obstruction. Okay. Sorry, this slide came in between. Okay. These are the non-malignant conditions which causes diarrhea, like constipation. Okay. When the peristalsis is affected, the patients with, like I said, paralytic ileus. In patient with paralytic ileus also, they'll have this kind of constipation. So MBO is malignant bowel obstruction. Malignant bowel obstruction is bowel obstruction is caused in malignant condition and other condition. Okay, like in paralytic ileus, patient having constipation later can have a malignant like a bowel obstruction. So we will be discussing about malignant bowel obstruction that is caused by malignancy. Okay, obstruction caused by malignancy, and most of the time it will be caused by malignancies in the pancreas, in the colon, rectum, ovaries, etc. Okay. So according, there are different classifications. So according to the extent, we can classify it as partial obstruction or complete. And according to the level, is it a single level or multiple level? Is it a single obstruction or multiple obstruction? Or because of the etiology. Etiology is a mechanical or functional. That is, there is something blocking or it is because of a functional problem. So I'll show a picture of partial obstruction versus a complete. Partial means there is a lumen left. The food can pass through the little opening, and if it is a complete obstruction, the food cannot pass. So also at different level, you can, I've just shown a picture of alimentary canal, and you can have this kind of obstruction at different level, at the level of esophagus and at the level of gastric outlet, the second one, at the small intestine and at the large intestine. So anywhere you can get obstruction. So the why I said this, because the level of obstruction decides the symptom. Okay, where you get obstruction, the symptoms differ. I'll show you what it is. High the level of obstruction, more the level upwards in the small intestine, stomach, esophagus, the patient will be getting vomiting early because the food fills fast and it will come out. Patient will get vomiting early. And the vomiting will be very large in quantity. It will be bilious and the patient might can have a very umbilical pain. So this is when a patient is having a high level of obstruction. That is in the higher level. But in the lower level, large bowel obstruction, high level and large bowel obstruction, in the large bowel obstruction, the presentation will be late. The patient will not be having early presentation and all. After the progression, lot of time, the patient develop abdominal distension and sometimes they will have constipation. So these will be the symptom with large bowel obstruction. High level means stomach and initial part of intestine. But in the large bowel obstruction, it will be abdominal distension and constipation. So the red flag signs for complete obstruction, this you should know. Patient will be telling, not a passing flatus. Like you have to ask, nobody will come and tell you they are not able to pass. You have to ask, okay, are you passing flatus? And the patient will be having constipation. The patient will be having abdominal distension, continuous nausea and vomiting, and sometimes furious diarrhea, vomiting fecal matters, and colicky abdominal pain. If the patient is telling all these things, you should always suspect a complete obstruction. You should suspect all these things are very typical. Okay, we can suspect like very easily when the patient, if you know these things, it will be easy to identify. So a little pathology will be, I'll just this is very simple because when there is a obstruction, the fluid or gas retention will be there. So this increases the intraluminal pressure. When the intraluminal pressure is increased from the gut wall, certain secretory motor neurons will be stimulated. Okay, and this in turn increases hypersecretion. Again, the intramural luminal pressure increases. So it's a vicious cycle. Initially, there will be gaseous distension that in turn causes hypersecretion, and this cycle keeps on rotating. And the patient will get abdominal distension, nausea, vomiting, all those things. Okay, you need to know this because it helps. This is how we tackle it. So it is common with intestinal obstruction. It is very common with bowel or ovarian cancer. Often multiple sites are involved. Then a plain X-ray abdomen will be helpful in identifying it. And before starting any treatment, you have to consider the quality of life because most of the time in a malignancy, all this happen in a will be happening in an advanced stage, this kind of obstruction. So you have to think twice before starting any, not starting treatment. Before starting any treatment, you have to think about it. So what investigations we can do? We are suspecting it. You can do an X-ray. You can do an X-ray why do we want to do an X-ray? To find the level of obstruction. Where is the obstruction? And you have to take a CT to know the cause of obstruction. But this too should not be done blindly. We have to think whether if we are doing this, is it going to help the patient even if they are identified? So this X-ray is very important. You will get as a question. Total intestinal in patients with total intestinal obstruction, the X-ray looks like this. Okay. See, there are multiple air fluid level, lot of gaseous distension. The black color is gas and different level of air fluid level. So this X-ray is typical of intestinal obstruction. Okay. You should not forget this multiple air fluid level. You should be able to identify. See, there is gaseous distension and so much. In this slide also, see, the flat lines are the air fluid level. And there is gaseous distension of abdomen. The black thing is air. And the white straight lines are fluid. This X-ray is done in an erect position. Okay. This X-ray is specially done in erect position. So, before starting the treatment, we have to consider all these things, the age of the patient, the quality of his life, status, stage of cancer, future anti-cancer treatment option, malnutrition, cachexia, concurrent illness. If a patient is in end of life and you are suspecting this thing, bowel obstruction, is it needed to take him to a hospital, sending him, referring him for a CT? Is it required? That's why we are talking about this. We have to think about the prognosis of the patient also, not like simply sending them for investigation. Also, the extent of the disease. So the disease has spread so much, and there are multiple level of this thing, and we have to think about it. So these are the patients with poor prognosis, widespread tumor, deranged metabolic parameters, patient with ascites, severe nutritional deficiency. You can think, right? All these patients will be having a poor prognosis. Previous radiotherapy to abdomen, multiple sites of obstruction, poor peristalsis due to diffuse carcinoma peritoneum, poor performance status. So initially we are starting with the management, few things I'll be discussing. So initial management, we'll give a rest for gut for sometimes. For ask the patient not to take a lot of food at once. You can restrict fluid, food for can ask them to reduce the food. You can give sips of fluid or hydrate through IV or subcutaneous route. It's not like we keep the patient NPO, but still you can ask them to reduce, give the gut rest for few days. Correct the electrolyte imbalance. Hypokalemia and also can cause this kind of obstruction. So you have to correct the electrolyte imbalances. So now coming to the treatment, this is very important. You have to know what all treatment we give for intestinal obstruction. There are only very few treatments, so we have to know about it. Okay. So starting with the pharmacological thing, we'll start with the corticosteroids. So steroid we give, the common one is dexamethasone, the superstar of palliative care. Dexamethasone 16 milligram IV in a day because it is very long acting. Usually we give it here in the morning because after 3 p.m. and all, like late administration, not 3 p.m. A late administration might cause insomnia. Sometimes Dextrona can cause insomnia. So we usually give a higher dose of steroid. 16 milligram is little big, right? 16 milligram of Dexona in the morning. And also we'll give it for 3 to 5 days and we'll see whether it is benefiting the patient. Simply giving the steroid and if it is not helping, we have to stop it. But this is the helpful method. So we'll try it for at least 3 to 5 days. Okay. And so how does steroid act? Can someone tell? We use steroid in so many ways in palliative care. Can someone tell how steroids act? How does steroids act? In a very simple way, steroids are very helpful in most of our malignancies.
Reduce
Yeah, it's an adjuvant. Okay.
reduces the inflammation.
Yeah, reduces the inflammation. Also, it reduces the peritumoral edema. Wherever in the body you get a tumor, there will be some amount of edema around it. That is known as peritumor edema. Around the tumor, peritumor, you will get a edema. So here also our malignancy in the bowel pathway, there will be edema. So if we give steroids, at least there will be some reduction in the space and at least something will go down through the little small lumen. So that's why gives dexamethasone. Okay, so you have to tell like for reducing the peritumoral edema. Okay, it is an anti-inflammatory also. Yes. Now, something you have to know about the pain in intestinal obstruction. A patient who is having a malignancy in the abdomen is coming to you with pain. The type of pain here is important. That decides our management. Because there will be sometimes there will be colicky pain. The intestine will obstruct and it will peristalsis will cause colicky pain. How does it happen? Abdominal colic is due to peristaltic waves against obstruction. So in that case, we give hyoscine butyl bromide. That is an anticholinergic agent that reduces the peristaltic activity. Do not give prokinetic if suspecting a complete obstruction. We'll talk about it. So if a patient we are suspecting intestinal obstruction is having a colicky pain, we will give a anticholinergic. But if it is a non-colicky pain, okay, no problem. He's not having a colicky pain, but he's having some kind of nociceptive pain because of the tumor, and he's only describing it as a pain, nothing like strangulating. The patients will tell, okay, colicky means they'll tell that abdomen is like twisting and all. So if it is a non-colicky, and if the patient is having nausea and vomiting, we can give metoclopramide. Metoclopramide, how does it act? It increases the peristaltic activity. Our perino, it reduces the stasis, it increases the peristaltic activity. But what if we give this metoclopramide to this colicky patient? Patient is already having peristaltic waves against the tumor. Each time the peristaltic wave against the tumor, patient will have colicky pain. And you are giving perinom to this or metoclopramide to this patient, that will can worsen the pain. So you have to be very careful with the type of pain the patient is describing. And also this happens when a patient is having a complete obstruction, a patient can get a abdominal colicky pain. And if there is, that's why I've written, if only partial obstruction, the patient is able to pass a flatus. In partial obstruction, the patient will be able to pass at least some stool, at least some flatus and all. But complete obstruction, nothing will be there. Complete constipation, no passing fetus, abdominal distension with colicky pain. Okay, so that's how the management in pain differs in like intestinal obstruction. Also, in nociceptive pain, the patient can have the tumor will cause irritation here and there, and there will be nociceptive pain. For that, you can give morphine. Okay, morphine you can either give it as a continuous infusion or otherwise as a bolus dose. So that's what we already told here. So the patient with intestinal obstruction, the most common feature will be patient having nausea, vomiting, and constipation. That's how we identify. Okay, then there is nothing coming down. So you should understand, and everything he is taking is coming out also. So the one of the important problem there will be this and nausea and vomiting. So our first drug is dexamethasone, steroid. Okay, we dealt with the peritumor edema. The next one is the pain that we told about colicky or non-colicky or nociceptive pain. Okay, the next problem will be antiemetic. Patient will be having continuous vomiting. When the disease advances, no, sometimes these patients will vomit fecal matter also. I have seen 2, 3 patients vomiting fecal matter. It is very distressing for patient and for the family. That is there in the advanced disease. But most of the time, the patient will be having continuous vomiting. So, if the patient is having a partial obstruction, metoclopramide, anti-emetic, so always when a patient you're suspecting intestinal obstruction having a vomiting and if he's having a non-colicky type of pain, you can start an on antiemetic metoclopramide. We can give it as 10 mg TDS to a Italian. You can increase up to 120 mg in 24 hours. I told yesterday, no, metoclopramide, one important side effect of metoclopramide in higher doses. Hope you all remember that. I'm not asking. Okay, then so you can start with a very small dose and you can increase the dose very slowly. Also, haloperidol can also help in reducing the nausea. Okay, ondansetron, we told in the last class we told a lot about ondansetron, gut wall, the gut wall distension. Chemotherapy drugs and see here gut wall distension causes releases of serotonin, and we can give a cetron anti this thing for reducing it. Okay. So on the MSET is also helpful, but we usually prefer metoclopramide if the obstruction is partial and if it is non-colic. So we give hyoscine butyl bromide anticholinergic. It decreases the peristaltic activity, that the peristaltic wave will reduce, and that will be helpful for the patient. And also it has an anticholinergic, means anti-secretory, right? It will reduces our secretion. Remember the pathophysiology, the fluid and gaseous distension causes the gut wall to expand and thereby increasing. Hypersecretion is the problem. So we'll keep a barrier for that. We'll give an anticholinergic. That is hyoscine butyl bromide. That one very common brand, Buscopan. What is Buscopan? That is hyoscine butyl bromide. We give it for as anticholinergic to reduce secretion and to reduce the peristaltic activity. Do not give hyoscine butyl bromide along with prokinetics. Why? Both have different action. A prokinetic increases the peristaltic activity and hyoscine butyl bromide decreases the peristaltic activity. So there is no need to give, sometimes it happens both for efficacy. We give metoclopramide and we give this thing. It should not be given like that. Okay, both have opposite action. Now there are something called octreotides that's very expensive. That will also reduce the secretion. So that is also given, but we don't use it very commonly. So in partial obstruction also, this we were talking all these steroids, all these antiemetics, all these analgesics, all I was talking about complete obstruction. In partial obstruction, we can give steroids to reduce the peritumor edema, and we can give metoclopramide. That will increase the peristaltic activity. Some that tumor will be there, it will be like the gut will be like this, and when we are giving metoclopramide, it increases the peristaltic and helps to overcome this partial obstruction. So in a nutshell, very we can tell that we can give what if someone asks you, if some doctors ask you, or someone asks you what are the treatment you can give for a patient with intestinal obstruction. You can tell dexamethasone. Dexamethasone should come first. Okay, that is a that is very actually clinically it is very helpful. We can see a lot of difference in that. Symptomatic relief will be much better. Then you can give either metoclopramide or hyoscine butyl bromide. Okay. In partial obstruction, you can give metoclopramide. But if the patient is having complete obstruction, you can give hyoscine butyl bromide. Okay. And if the patient to control the nausea, you can give haloperidol. Haloperidol you can give up to 20 milligram in a day as subcutaneous infusion. We start with the very small dose. In palliative care, we always start with the very lower dose, and if we feel that we need to titrate it, we need to increase it, we have to increase it. Okay, I'm just telling the upper limit of all the 120 and all. We don't give it like that. We start with a lower dose, then we'll increase it. So we finish the pharmacological part. And if the patient is having a good prognosis, okay, a young patient who is having good prognosis, who is responding to malignancy, right, something like that and all, you can have palliative surgical corrections like resection. Sometimes you can resect, if the doctor, the surgeon is telling, they can resect that part where the obstruction is causing and ligating it, the other things. It's a very big surgery. But if the prognosis is good, we can do that. We can do a stoma, colostomy. Can before that obstruction, we can give a stoma. The doctors can give a stoma. Then stenting can be used, peg tube insertion, and gastric outlet obstruction. All these are optional. Most of the time, there will be advanced malignancy. Patient will not be fit for all these things. But you have to know that all these surgical patients, caregivers will be asking you. Like you will be able to tell all these things. Okay. So that's the end of our intestinal obstruction also. Okay, doubts? We can ask doubts. You can ask clarifications. You have anything like that? Hope you have understood at least something. At least few points have gone to your head. No need to read it. It should be stored in your brain. Can't read. You can't like by heart everything. That's why I was stressing some points. So many points will be new to you, but some points we'll be learning first time here. Anyone has any doubts, any comments, anything like that? Feel free to share.
You can unmute yourself or you can put it in the chat box.
Anything? Hope you have understood the session. Okay, then we'll go to the presentation if nobody is having any doubts. Osmotic laxatives. All these osmotic drugs, what they do is they'll draw the water to the lumen from the body. They'll draw water to the lumen to increase the quantity, and that thereby the action of this laxative is to smoothen the hard stool. So when we give a drug which is osmotically active, the water goes from its higher concentration to lower concentration. That means the water will reach the lumen. So this will be soaked and it will become smooth, and the stools will be passed. But the problem is when so much water is gone, the patient will get dehydrated. We can prescribe lactose for patients. Okay. Yes, but you should know the difference between the two, you should know. Okay. So
We can move on to the case presentation. Our case presenter will be Shreya Sanjay Kamble. I welcome ma'am for presenting the case.
Case presentation. Myself, Shreya Kamble. I'm working in a CPC as a staff nurse. Then patient details. Age of the patient 48, gender male. Diagnosis CS stomach with abdominal pain and weakness. Next. Presenting complaints. Rectal bleeding, weakness, abdominal pain, fatigue, incomplete bowel movement. Then history of illness. Patient admitted in the hospital with the chief complaint of abdominal pain, weakness, fatigue, and rectal bleeding, and diagnosed with gastrointestinal symptoms, that is colitis. Due to these causes, decreased his daily activity and pain in stomach, weakness. Then examination. Patient is conscious and oriented. Then we check vital signs, that is temperature 97.6 degree Fahrenheit, pulse 87, respiration 20, BP 120 by 90 mm of Hg. Pen score of the patient is 6. Treatment and significant investigation. Patient is admitted in government hospital, male general medical ward. All routine investigation done, which shows as follows. BSL 128 gram per deciliter, urea 30.5 mg per deciliter, create 1.18 mg per deciliter, HB 11 gram per deciliter, dengue is negative, and USG done. Psychosocial aspects. 48-year-old married person living with his wife and 2 children. He is working as a teacher in a college as a teacher, and his wife is a housewife. Now she is taking care of him, and nobody other source of money in his family for survive. So he go to his home early as possible. Medications. Tablet tranexamic acid 500 mg BD, tablet tramadol 50 mg TDS, syrup primafene 15 ml HS, tablet beta-histine 20 mg BD, tablet pan OD, tablet ethamphylate BD, tablet lorazepam 1 mg HS. Main concern: age, CA stomach with abdominal pain, rectal bleeding, fatigue and weakness. Summary: 48-year-old person admitted in government hospital, male general medical ward with diagnosis of CA stomach with abdominal pain. Discussion points: do we need to palliative care for this patient? What are the problems facing by this patient? What can be done for patient and his wife? Thank you.
Okay, thank you, Shreya. So the first question you should answer: do we need palliative care for this patient?
Yes.
Yes. So we should not have a second thought. This patient should have palliative care support. In my topics aspect, like what we discussed today, this gastric carcinoma patients, most of the time in advanced stage, they will have gastric outlet obstruction. They'll present with all these kind of nausea, vomiting. So the problem with this nausea and vomiting is that the family will be in so much distress. Seeing a loved one vomiting continuously or suffering will be a very, very big suffering. So that's what. What can be done for the patient? Already it is told that we have started the Tranexa. We can control the pain. Most of the patients with CA malignancies, they'll present with this kind of gastritis. So we'll simply ignore them with the PPIs, pantoprazole, and all those things. But definitely we should start, if the patient is having pain, very severe pain and all, we should definitely start morphine for this patient. And we should counsel the family, maybe where the time, the malignancy, where the depending on where the malignancy is, we should counsel the family regarding what are the problems with the this thing, and in the future all these things can happen. You have to tell, like the problems with intestinal obstruction, problems with nausea, vomiting. Most of them will be having nausea, vomiting. Gastric problems will be nausea and vomiting and pain. So that should be mentioned. Okay, that should be addressed. Do you have any other comments on this? Anyone has any comments? Anyone wants to make any comments? Anyone has come across patients with intestinal obstruction? Have you seen anyone? Anyone? No one. No one has seen. Okay, we have in our institution, we have I have seen a lot of patients, and only 2 patients, I guess, with the total intestinal. Most of them will be having a partial obstruction. Okay, most of them will not go into the complete. Will not be able. Before that, only they'll pass away. But some patients, they'll go to this complete obstruction stage. That is very distressing. That is very difficult to manage for both the patient and for the caregiver. Imagine patients vomiting fecal matter with the bystander. The smell will be very difficult. They'll get that smell. They will vomit after that. So it is a very difficult thing. We have to know, we have to anticipate few things. We have to counsel them. We have to reassure them because it is a very worst condition. We have to give all our support. We have to reassure them. It's okay. The smell is, it's okay. The most of the time they'll be thinking, oh, what the sister will think. Oh, it will be difficult for them to wash and all those things. Everyone will be hesitant to come to my room. So the prognosis of such patients will be very, very less. Okay, when they start vomiting fecal matter, they will not go for more than 3 to 5 days. Not like very general. I'm talking not very generally, but usually it was like that. Okay, so you have to know about this. Intestinal obstruction can occur. Most of them will be having partial obstruction. You have to pick it. You have to suspect it. Sometime in rural setup and all, we won't be able to take the patient to hospital. Okay, Then we have to manage at home care itself. Then you can do all these things. You can try these things. It's not like you have to diagnose with a X-ray. You have to diagnose with a CT scan to like make a diagnosis. You can write as suspected intestinal obstruction, and we can try with dexamethasone, steroids, whether he's improved. We can see that. We'll be able to see the change. Okay. Any comments? Any doubts? All clear? So I think everyone will be able to pick up at least suspect intestinal obstruction and rule out constipation. Okay. Most of them will be not telling. Nobody will tell. Okay. In the first run itself, they'll not come and tell you that they have constipation because um, in our society it's like that. It is very awkward, or everyone will feel shy to talk about all those things. So prompt, ask, get it from them, make it clear, make them understand everything. Okay. We'll wind up the session.
Okay, thank you, Nayana and Doctor, for the wonderful presentation. Thank you all for participating. Thank you, Shreya, for presenting the case story. Thank you all for participating in the sessions actively. Thank you. Let's see you in the next session. Bye.
Thank you all. Bye.